Good afternoon, everyone. Welcome to this first DASH webinar of 2024. I think we have an exciting topic that we'll be hearing about today. My name is �W𝐨𝐫𝐞𝐚 𝐒𝐲𝐿. I'm one of the people involved in DASH with particular focus on cohort data. I will share just a couple of slides about DASH if you don't know it yet. DASH is short for Data Science Center in Health, and the vision of DASH is for 𝐢𝐧𝐼 to be an international leader in data-driven healthcare innovation. It's quite a broad topic. Why is this so important? Next slide, please. We firmly believe that data-driven innovation contributes to the goal of building the future of health, which is the focus of the 𝐢𝐧𝐼, and also has the potential to transform healthcare as we know it at this moment. Next slide, please. Within DASH, we have a number of facilities and activities that could be very valuable for the research and education and clinical work that you're doing now. And these facilities range from AI think tank, machine learning lab, an ELSA lab, an IT lab, and different communities in the field of machine learning, clinical cohort data, application of AI, and e-health. And DASH also has, if you can go just back one for a moment, one more back. Yes. DASH has project support. It has education activities just like this one. It has also activities for impact and outreach and funding opportunities. And we have just currently running a grant application round. These are the 4 DASH experts at this moment: Peter van Ooyen on machine learning, Job Doornberg on clinical application of AI, Esther Metting on e-health, and as I said, I'm focusing on clinical cohort data. Next slide, please. So I think today we really make a very great start of the year with this topic, which is very central and important when we're talking about data-driven innovation in healthcare. I would kindly ask you to put your microphone on mute unless you ask a question at the end of the session. You can also raise your hand if you have a question, or put the question in the chat. This webinar will be recorded and available for later viewing. If you would like, if you have a question later on, you can also ask it in Dutch if that is more easy for you. Now it's my pleasure to introduce the speaker of today. We actually met at a cardiology conference in Graz last year, and I was impressed by the work that Diether is doing. We were both in a session on AI in healthcare. Diether Kramer is lead data scientist at the Styrian Hospital Holding in Graz, as well as CEO and co-founder of a startup company, Predicting Health. And he has been conducting research with health data for over 15 years. He has led numerous scientific and development projects, and Diether is also lecturer for the Clinical Decision Support course at the FH Joannem University of Applied Science. And it's my true pleasure to be able to introduce him today. And Diether, the floor is yours. Let me just tell the topic of the title that you gave us: Unlocking the Potential of Machine Learning in Health Predictions. Thank you. The floor is yours.
Thank you very much. Thank you for having me. Thank you for inviting me to this session. I will try to share my screen with you guys. Meanwhile, I also would like to thank you for all those who show interest in the topic I'm working on, and hopefully you get some new insights. If I can have a short sign, but I think you can see my screen now and the presentation, that's fine, okay? So this is a Dash webinar. It's about unlocking the potential of machine learning in health prediction. That's the title we call. The subtitle is giving you a little bit more insight. What I'm talking is also a little bit deeper insight. It's like benefits of predictive analytics from electronically medical record data. All what I would like to explain to you is like that there is enough data around to get additional insights, and I will show you use cases and something more. As Rosemary already told, I'm working for a hospital holding. It's a complex name probably for you to spell. Styria is a federal state in Austria, a population of about 1.2 million. And the hospital holding covers about 90% of the hospital beds in this region. And as our work has been quite successful over the past year, we also founded the company that we could provide our software, our tools, and our knowledge also to third parties. And this is called Predicting Health. On my very first slide, I would like to say thank you to lots of partners so that you don't have the impression that I have done this on my own. We have been in several research corporations, of course, mainly with Austrian partners, also some international partners you can see on the right. Don't want to go into my detail, but my team and I are pretty much thankful to have this opportunity. What I would like to do also today is like I don't want to dive too deep into the topic, because what I have seen on the list is that it's a very diverse or heterogeneous audience. So in terms of the profession, of course, and that's why I will give you some more basic stuff in the very beginning, and then now we shall see some use cases. So what I think of is that machine learning based predictions, so what we are talking about, are small, but I think a very essential part of the future of the healthcare. I will show you what it is in the beginning. I would like to give you some arguments why it should be used, how it works, and finally there's the two use cases I have prepared for today, and then a short outlook. And depending on the time, I would like to complete my presentation within the next 30 minutes, that there will be enough space for any questions in the end. If there is an urgent question of understanding, feel free also to interrupt me shortly, but I would prefer to have the questions in the end. Well, let's start with a very easy slide here. How do predictions work? So we have to have the same understanding of this topic. What is a prediction? And the prediction, if you see this hand, and of course, I know it's pretty famous in Austria also, that you have this thinking of there is a lifeline on your hand. I assume all of you know that this is nonsense. It's not true, but it gives you an idea of what a prediction is. You have nowadays, if you look at your right hand, for example, an information what your life expectancy could be. Yeah. So, I mean, it's not true, but you have an information today. And if we summarize this a little bit more specific, so then we can say a prediction, or it's a forecast. It's kind of a statement of a future event. And it is often, but not always, of course, based about experience, information, knowledge we have nowadays, okay? And if we're going on and complete this a little bit more, we can also say, well, the information needs to be somehow accurate. So the lifeline for sure is not, okay? But if you have an accurate information about the future, it is in many cases is really impossible to have an accurate information about the future. So prediction can only be useful to assist in making plans about possible developments, okay? And it's kind of, if you're thinking of a weather forecast or these kind of things, it's nice to know if probably tomorrow in the afternoon it's going to start to rain, to be prepared therefore, okay? But need not to be that there will never be a 100% probability of raining probably, but it's fine if you know it could very likely to do so. We need to agree also on some other definitions and assumptions that, as I usually have kind of debates after my presentations, and sometimes it's like misunderstandings, and I would like to cover a couple of one at the very beginning. What I'm doing with my technology, the technology we are developing or using, actually we are not developing technology, we are applying it, but what it is, it's a prediction, and it's not a medical diagnosis. So we're not replacing what doctors are doing by diagnosing diseases. We're making predictions about risks. And also in medicine, tools for these kind of things are already around for a long, long time, but it's more like called scores. but the scoring, targeting, profiling, however you'd like to call it, these are existing. Some of these scores already have been developed in the 1940s, okay, mainly in the United States. What also is kind of an important point is that we have some risks in terms of health are avoidable. Like the risk of falling in the hospital is avoidable. A stroke is avoidable. And the list is long. This is to say, some risk factors can be modified, you know? So if you can avoid the risk, if you modify something, it would be good. And this leads us to this kind of the occurrence of a risk can often be avoided also by simple means. If you think of a risk of falling, for example, and actually only if the right information is available at the right time. So if you are getting informed that this patient has that certain risk, you can probably act and need not to react on that. So, and this is something that leads us to the point is why should we use predictive analytics? And one argument is that we are likely, or we want to increase patient safety. Okay, so if it's using these approaches and you can predict the risk for a certain patient, then you probably could avoid it and increase his patient safety. And the other argument, which is also almost in the same direction, is like we want to be more efficient, you know, and actually meaning like to be more efficient is something which is triggering us now very, very strongly. You know, I think it's the same in the Netherlands as it is in Austria. We have an aging population. An aging population means there are not more people that need to be taken care of and less people who are in the workforce and can take this care. Yeah. So that is something like we not only want to be more efficient, we need to be more efficient. So, and these kind of technology we are using here can fulfill these aims. If I start with that, I also would like to address one more definition. So this is like, what does it mean to be efficient? I mean, and there are kind of different approaches. As I'm an economist by training too, I also have a kind of a very strong idea on that. And this means like, first of all, there is one definition which is like ineffective, okay? And I'm making this symbol here. It's like, means like you have not hit the target. So that's something which is happening, okay? If you're effective on difference, means like reaching the target, but as this arrow shit symbol here is, you're going like circles to achieve it, okay? So this means like in the end, you reach the target, but you could have been faster, or could have been a little bit more directly. And this is the definition of efficient, okay? And there's something like a misunderstanding between the terms of effective and efficient. We don't want not to reach the target, but we want to reach the targets a little bit more directly. And if we come to the topic of the healthcare sector, healthcare setting, yeah, what if you're thinking about being effective, would like to mean like we're giving preventive actions to everyone. And as this picture is symbol to you is like also this population is kind of heterogeneous. So some are more similar than others, but to avoid risk, it's not the idea being efficient to provide preventive action to everyone. And then there is also like if you see this symbol of population here, in some cases, the risk could be overlooked. So if you pick it by random, or if you leave it alone, you can probably not get the right classification of risk of a patient or a person. There are a couple of reasons for it. We have hospital information systems that are completely loaded with information nowadays. Lots of data is there for patients, a lot of discharge letter from former hospital stays, and so on and so forth. You can't oversee all these kind of things because there's a time constraint. Your workload is somehow limited. So medical staff can't look into all these kind of information that is probably available. And on the other side, we have from time to time complex risk patterns. And these cannot be perceived and assessed by human beings, but could be by computers. And there might be even more. So if you see this population, then you probably have the idea that only some of those are at risk for falling. We would like to address them. correctly, because you don't like to make any preventive action against fall for a person who is probably not at risk. Same is true for something different. I'll come to that in more detail later on. A swallowing disorder, yeah, and subsequently an aspiration pneumonia. Some people have this kind of swallowing disorder, which means like your food, your nutrition, or drinks are going the wrong way down and it leads to a fatal event. And you also want to find out who is at risk at that probably and give them the preventive action or do something to avoid the complications. It means like every patient is different. And the question now is, how could we launch a personalized risk prevention? So, and this is what I'm actually talking about, making it more personalized, the risk prevention, so that you can address people. And what I would done here, I mean, this is kind of simple PowerPoint trick, is like highlighting those. You want to have kind of a tool that is going to highlight those patients who are really at risk. And what this should do here, or should show to you, is you have this kind of tools going through the whole population, screens, and find out who is at risk. So you need a target-oriented, and for a target-oriented preventive action, a screening tool is needed. Yeah, and that is like thinking of, well, I've mentioned already, there have been scores around a couple of times. I would like to give you these and see these. So you do different approaches, and there's a medical score, and you have probably heard of the delirium observation screening or the Q-risk-3 score, meanwhile, Framingham risk score, and many more. So I think if you look into Wikipedia, you find a list of about 50 or 100 different medical scores that are doing actually somehow similar things. Sometimes they are more for diagnosis, not for so much for risk assessment, but usually the idea is pretty much the same. And they have a huge advantage over this technology I'm talking about, is because these scores are well established and they are published in lots of journals, and they are discussed in the community, in the scientific community, and they give you an insight. They have, but on the other hand, a really big disadvantage. If you see here the screenshot, I think from a Q-risk-3 score, you have again record necessary parameters. So additional workload is needed. For example, here, if you see, is there a blood pressure treatment, or you have to fill out difficult things? Probably some of this data is available in your hospital information system. You can use it with an interface, but other data probably not. And you have to fill this core completely. And if you probably are not trained in this kind of field, it's probably a little bit tricky for you to find out where this patient suffers from a kidney disease and what kind of stage he has. So in any case, a score leads to additional workload, and this is what we want to avoid. And this is when it comes to this targets thing here again, means like it is probably effective, but you're going not directly there because there is a way that is more efficient. And also, what I have to say is, the scores are not as good as machine learning algorithms could be. I will show you. The reason is scores can only consider linear relationships within the predictors, and they are also limited in the number of items you can ask. You know, you can't give like 600 parameters like you could do in otherwise. The option B, you take a machine learning based approach, and machine learning has a lot of advantages. First of all, it's automated. You can use it automated. It's a fast assessment, and it can really fast sift through a lot of data in a really short time, whether it's structured or unstructured. Okay, so if you use these kind of automatic, another thing is if you're also using collected data and you're going to train the models that they are aware of the amount of data that is available, then there is no additional workload for the staff. So you can use the data as it is already available. And also if it's limited, the algorithms in most cases perform pretty well too. Machine learning algorithms deliver a better predictive performance, and there might be lots of reasons. If you come from statistics or whatever, you can know that you're able to combine data in nonlinear and highly interactive ways, which can't be done by a score, for example. So this means like taking into account correlation between variables. This is what it can. But this leads to a disadvantage of these algorithms. The main disadvantages which we are talking about nowadays in the field is about explainable AI, actually. The predictors are not causes. So that means like correlation and causation. Okay, so it's pretty difficult in the end to find out what kind of feature made the algorithm bringing up his decision finally. Okay, so well, how does it work? And this is kind of on a very low level, but to explain, make it easy to explain for most of you probably know already. Take past patient biographies, okay? And we're using routine documentation. So that you don't need to enter data in the end. So you have to train a situation that you will find in real-time setting then again. And so in the machine learning patterns, machine learning methods can recognize the patterns in thousands or millions of biographies. So you can train models, and this is not in terms of hardware any issue, or there are no constraints in terms of hardware like that. And if you have these patient biographies from the past, you can train the algorithm. You can simulate the situation you will find later on if you want to apply this algorithm for predicting a risk or whatever. And this algorithm, in the end, will then be applied to identify the patient, an incoming patient, or population might be not an inpatient, could be outpatient, or whatever kind of situation. You have to have the data, you can train the algorithm. If you have these supervised training models, then you can go further. If we have made it now, or what we have done now, this is software as a medical device, okay? And we have brought it into the clinical workflow. Okay, so what does it do? It takes the data. If a patient is admitted to a hospital, for example, it takes all the data that is available in the electronic medical records, like demographics, like diagnosis, laboratory value, nursing data, medications, and so on. Usually we create models with around 600, above 600 features, sometimes could even be close to 1,000. And if you do that, you can just use this data. You have your pre-trained algorithm from the past biographies and give this algorithm this data and say, predict me what's the risk, and I can do it. And then you just have to bring it into your hospital information system, as we have done it in a couple of use cases already. So this is like you see here at the top. I get the screenshot later on in a little bit better resolution. But if you see here's a list of patients, and you mark those who are at risk for something. What you can see here is a MACE risk, as a major adverse cardiac event risk. This is screenshots from this kind of topic. So actually, it's a pretty easy software architecture. Still, it's software as a medical device and have to take care of, but it does this completely automatically, and you need no further personal resources, only technical resources, and those are really very easy to achieve. To give you now a little bit of better idea how this is working, we're going to look into some use cases. See just a couple of screenshots. The first use case I would like to give you is dysphagia. Dysphagia is the swallowing disorder. Don't confuse me with a medical expert. That's what I'm talking about. These kind of diseases is something they have told me, and I don't ask me too much questions about the details of these diseases or syndromes, please. But actually, what it is a swallowing disorder, and it can be or could be overlooked at the very beginning of, for example, a hospital stay, an inpatient stay, a planned inpatient stay, and the consequence could be an aspiration pneumonia. Okay, so imagine the scenario: you are a patient and you are admitted to a hospital. Okay, so what is happening in the very beginning is that you are waiting for your first therapeutic or whatever kind of session. So what is going to happen, and this is, I think, kind of an international code of politeness, is you providing someone with a cup of tea probably, or a coffee, or give him some food, okay? And in this certain case of suffering from swallowing disorder or having a high risk having that, this could be fatal, you know? Because what happens is it goes to the nutrition, goes the wrong way. So it means like you could, in the end, suffer a pneumonia. And this is a life-threatening complication, which leads to a loss of quality of life. And also, what this means is delayed of treatment. I crossed out the surgery here. Probably it's not possible that the original reason you have been admitted to the hospital can't be carried out because you have this fatal complication. there is a very little number of what is the economic costs of this. And I also only found data from the United States, and they estimated in 2005 already, so some 20 years from now, already on $17,000 per event. We don't want to compare the United States health system with ours, but this is the amount of money which is in terms of cost, what happens if you have a swallowing disorder, and not an overlooked swallowing disorder. The other way, if you see this kind of process of a patient, a simple process, what could happen? What could be the other way? The other way could be you're admitted and you get an attention here. There's a high-risk patient. And the easiest solution then would be like, you have this right information at the right point in time. You remember my first slide, hopefully, or one of my first slides, hopefully. If you have the right information here in hand, you can pretty easily say, well, if the risk is indicated, there will be no food until further clarification, or no food until without supervision from someone. Okay, so just to avoid this risk, it needs to be clarified in the end and all the stuff. But what happens is you can't avoid this risk at the very beginning of a hospital stay. And in the end, hopefully the treatment will go on as planned. I give you this, what this looks like in our hospital information system, or at 2 clients where we have already deployed this software. The results of the calculation is within the clinical workflow. I don't know whether you're familiar with this kind of screenshots. This is an ISH hospital information system. It's quite famous in Europe. There are for sure some hospitals in the Netherlands also using it. And this is a patient list, okay? And you see on this patient list, I'll probably highlight it a little bit, sorry. It's the laser point here. You see in this patient list here, okay? You see here, this guy has a warning. It's a red one. So this has probably the machine learning algorithm thinks as a very high risk. This symbol occurs already at the very beginning of the hospital stay. At that time, the first data is available of the patient. Our algorithms already start to calculate whether this patient is a risk or not. Okay, and then you have this. Oh, sorry, getting rid of it. And then if you click on this symbol, a web application opens up. Okay, this guy called 𝐷𝐻𝐻 is not existing. Don't worry, this is a fake data here you see. But it should symbolize that. And sorry for that, this is in German. I don't have an English version of our software by now, but I think it's pretty easy what it shows. Diagnosis, the German word here, and you have the medication here and lab values and all these things. What it does, it simply summarizes the patient history to give the user an idea whether this high risk, in this case is delirium, is correct or not. So the user then can very fast verify or falsify also whether this risk is correct or not, and whether he should undertake preventive action or not. What I would like to show you is the algorithm of this page here. We have evaluated it in 2 studies. I don't want to go too much into detail in kind of our verification, but there are 2 studies. One is forthcoming pretty soon, and I would like to show you how good these algorithms are working, and we have evaluated in real time, so they have been implemented into the hospital. And in the first case, this is a general internal department and the geriatric ward, and what we can see here is that I put on this laser point again. What you can see here is they achieve a specificity of 84% and the sensitivity of 74% here, which leads to an area under the curve of 0.841. I don't know whether you're familiar or not with this concept of the area under the receiver operator curve, but usually it's stated that above 0.7 it's good, above 0.8 it's very good, and above 0.9 it's an excellent discrimination. This is also true not only for machine learning, every classification algorithm. So what we have shown here is that you can, let's stay with the internal medicine wards, the better one. We had 62 cases in the period of observation that suffered from dysphagia or had a high risk of dysphagia, and 46 of them have been already highlighted at the very beginning. So you have a good chance to cover almost 3/4 of these patients very early. And I give you the second slide here, which we have done even better, is on an ENT department at the University Hospital here in Graz. where we have a specificity of 98% and achieved a sensitivity, so the right positive cases of 82%. Okay, so from 51 cases, 42 were detected at the very beginning of the study. So this gives you a chance to act as soon as possible at the very beginning of the hospital to say, well, this patient is at risk, and probably we could avoid the complication, because then you have, in most cases, the right information in time. Also, and this is what I have to say here with you seeing this data here, we never will achieve 100%. That's true, okay? We have also classified 9 patients who have been at risk. The algorithm has classified as no risk, so there's still some space to improve the algorithms probably, but there's also kind of thing that we have to say, well, it should not only be the computer who's taking the decisions, also human beings should be involved. So this term of a human in the loop, you're probably familiar with that. No, it's not going. So the second use case that I would like to show is a major at-risk cardiac event. So this is an ongoing research project. We have a proof of concept already developed in one very general hospital. I give you some insights on that. First of all, as a MACE event, for those who are not trained medical doctors here in the audience, and for those who are probably not so familiar with this, the epidemiology of this disease, well, I have the data from Austria here, and I think it's the relative amount of percentages almost the same in the Netherlands. So we have about 40% of all deaths in Austria caused by cardiovascular diseases. That's a fact. And the consequences are often that we have much more inpatient stays or treatments in fatal cases. So we have in Austria an estimation by our federal ministry of above 1 million days of sick leave and costs of almost 5 billion euros per year. So as the population in the Netherlands is probably double as Austria, you probably find your data being times 2. What we do now from the literature, what the cardiologists are telling me, that early preventive measures could avoid MACE. And these numbers, according to literature, goes up to 80%. So I'm not an expert in that. The underlying disease is atherosclerosis, okay? So this is kind of an idea of how the medical doctors are trying to explain it to me. I try to explain it the same way, right? It's like a silent disease. And it's all about the plaque in your blood system you are having. So this is going to grow and grow and make actually this, let's call it the pipe, a little bit smaller and smaller. So the blood flow is not that as it could be. So there are 3 options. If this final stage here, having this plaque destabilization or plaque rupture already, there are more 3 options. So it could be too narrow to make a sufficient blood flow. You could also have this kind of thrombus, which then finally leads probably to a stroke or a heart attack or whatever. In worst case, even so, you have an aneurysm or a rupture. Okay, so this is going to be really a better outlook. And then there's this point that you can say you could avoid a MACE event, but the preventive measures are often very general. So this is our statement here, where he's saying we have a lot of campaigns saying like, oh, stop smoking, watch your diet, do more exercises, reduce your alcohol consumption, watch your blood pressure, and so on. But this is like, it's not targeted, okay? It's like giving this preventive action to everyone. And those who think you can pick something are picking something, and the other ones who probably not. So the patients at risk are not really addressed. And it's probably most of those guys who have a good idea about health are taking more care about their health, and those who have not, probably not. And this means like some people, these arguments are kind of abstract or probably fictive, okay? So, and then also like questions you also have probably heard of. I would like to live, and then who wants to live forever? So I'm doing whatever is necessary. And the idea of this project is like, if we address people at risk personally, the outcomes of the preventive actions will be increased significantly. In the best case, so this is a map of Austria. So in the best case, you can screen an entire population, okay? We have already evaluated our tool in a hospital at a surgical unit. So this is not in any context related to the cardiology or internal medicine department. It's a surgical unit because patients are there. You have access to data, to health data from this patient, and you can make a prediction. And what happens is then, what we have, the idea is we have like a kind of a dashboard, which is also again summarizing what kind of data has been available and saying, oh, this patient is at high risk and how is his risk compared in his age group, to his gender, and so on, summarizing the important features. And the simple idea is at the discharge time, the medical doctors can easily, probably you can't read this German, but it's like take it to the discharge letter or print an information sheet for the patient. Sorry, I need to use the laser here. So take it to the discharge or print an information sheet. So this is the options you have here, and then you can easily click on it. So this should be symbolized and have an information sheet. You're giving away to the patient or put it into the discharge letter. This is like a copy paste. So you copy it to the clipboard and put it there, and then the medical doctors can further start with like whatever kind they think is correct for infections. What we have found out, and this is kind of a situation that is in Austria, luckily we have it, we have the electronically health data, the 𝐿GA it's called. So this is kind of what we're using. And we have tried to use this data only and train this algorithm again. And what we achieved here is an area under the curve of 0.94. So this leads to the conclusion that we also have here a very high sensitivity and specificity for this training data, and that we could, if we could imply it, wherever this data point is accessible, this is every medical doctor in the inpatient and in the outpatient sector, wherever he's working, could address this tool and you can implement it. And if a patient is at high risk, you can start this process of doing some preventive, and it's very much more personalized. So they're kind of technical details. Finally, for today, I would like to give you a short outlook. We have a lot of tools already trained, or depending on a lot of fields we have trained algorithms. I showed you the dysphagia and the risk of cardiovascular disease today, but we have also done this with delirium, with fall, with malnutrition, nephrological diseases, and there are much more. There are for sure much more ideas how you can use it, but it's always like having some data from the past, simulate the situation that would be in the real world setting, train an algorithm and find out whether it works or not. And if it works, it could be a good assistant or a decision support system. What we are currently looking forward is also that we have kind of think of federated learning. I have prepared this one slide here, which is like you can train models in each or every different hospital setting, and in the end, you're probably able to put these models together. These wheels should symbolize the models here. So these wheels here occurring here, and then in the end, everybody has a better model in the end. Okay, this could be shared also with partners that don't have data. This should a little bit represent the Austrian situation, but it's true also on an international basis. Well, finally, last but not least, some thoughts that I have got over the past years. We have to engage a little bit more in a change of mindset for new technologies. Most of the time, the questions I get are kind of critical against the technology, or the quality of data, which is not any issue here. And also what we have found out, of course, is that those tools need to be integrated into clinical workflow. So if you have a clinical process with really addressing, look in the morning, or whatever kind of thing, look, is there at risk or not? But if it's not done, it's most people are very likely to ignore this kind of warning from time to time. My conclusion is that this kind of systems are working. They cost only technical resources, and it's a huge possibility to increase the patient safety and reduce healthcare costs. Okay, so and they are working. We have shown it now a couple of times. For today, I think it's fine. If you'd like to ask me any questions, please feel free to do so. You have my contact details here. I'm very happy to answer your emails too if you come with a question later on. Thank you very much for your patience. And hopefully have given you some nice insights. Thank you.
Thank you very much, Diether. Very, very, very interesting, at least to me. So it was a true pleasure to have Diether Kramer today with us. I would like to thank him and you as audience very much for attending this webinar. From DASH, we will be having regular webinars this year. And I kindly ask you to either check the website or any of the social media accounts. Also, you can subscribe to the newsletter, and then every month you'll get updated on new publications and activities from DASH. So if you want to take a picture of the QR code, feel free. And with that, I would like to end this webinar of today. I think we've got a really interesting introduction into the use of medical data from just from hospitals into predicting clinically relevant outcomes that can help to improve patient care. So I'm very thankful that Diether wanted to share his work and his ideas with us. And with this, I would like to thank all of you and wish you a very good evening. See you next time.